Hello and welcome to the Oregon Senate Bill 1606 webinar brought to you by Oregon Health Authority and Disability Rights Oregon. My name is Christine Getman. I use she, her pronouns, and I'm an accessibility coordinator with the COVID-19 Response and Recovery Unit, and I'll be facilitating today. Before we get started, I'd like to draw attention to our ASL on screen. There's also captioning available with this recording. If you prefer the information from this webinar in a different format or language that is more accessible to you, please email us at accessibility.team@dhoha.state.or.us. In this webinar, our presenters will go over the history of Senate Bill 1606. They will review key elements of the law and highlight key terms within the rules. At the end, we will share additional resources available to you and answer a few of the most popular questions. At this point, I'd like to welcome our presenters. Anna Davis, Health Facility Survey and Certification Program Manager with the Public Health Division, and Emily Cooper, Legal Director of Disability Rights Oregon. Welcome, you two. I'll let you take it from here.
I'll start. I'm Anna Davis. I use she, her pronouns. And today I'm wearing a white shirt and a red wine-colored jacket. And I have bright blue behind me, the blue sky that we're not seeing outside right now. And I am the Survey and Certification Program Manager. I manage a team of surveyors who survey across Oregon in acute and continuing care facilities. That includes hospitals, dialysis facilities, ambulatory surgery centers, hospice, home health. And we survey using both federal laws that are for the Centers for Medicare and Medicaid Services and the Oregon state laws and rules that apply to these facilities. And included within that is the laws and rules for 1606. And I will pass it to Emily.
Thanks, Anna. So I also use the pronouns she and her, and I also am a white woman wearing a wine-colored top. I promise Anna and I did not coordinate our outfits for today's presentation. As Christine mentioned, I'm the legal director at Disability Rights Oregon, and why we are so happy to be a part of Oregon Health Authority's presentation on Senate Bill 1606 is from the beginning of the pandemic, our office was getting calls and letters concerned about the rights of people with disabilities to have access to support people while they're in the hospital. And so just to give a brief introduction to the Senate Bill 1606, is what the law says is that a person with a disability has a right to a support person, regardless of where they are in the hospital. That could be the emergency department, it could be any other aspect of the hospital. And the reason that that was important is we noticed a lot of hospitals, understandably, were limiting visitors to hospitals based on the specific nature of COVID-19 and it being a respiratory illness that spread through breath, and so limiting the people who were in these settings. But the unintended consequence of that limitation was that people with disabilities didn't have the support they need to make informed decisions about their medical care. And so this law guarantees the right to a support person for any patient with a disability. And this is both during and after the COVID-19 pandemic. Next slide, please. So as I mentioned, the reason for this was to address the issue of limiting visitors to the hospitals. And what we made clear in this law is there is a difference between a visitor and a support person. Another analogy could be the difference between a beloved pet and a service animal. Those entities do separate functions. And what a support person does is it helps a patient with a disability help them either communicate or perform activities of daily living that hospital staff can't effectively provide. A good example of that is someone may have a care provider that helps them transfer, say, from their chair to the bed or from their chair to the restroom. And most hospitals don't have a one-on-one staff person in your patient room to help you make those transfers. Then on the communication side, it could be someone uses a specific dialect of sign language that maybe isn't ASL. So even if the hospital was required to provide an ASL interpreter, someone who is deaf or hard of hearing that had a specific type of sign language could have their support person in there to help them communicate to their doctors and nurses and understand what their doctors and nurses were saying to them. Next slide, please. So here's a little bit of a history. It will not surprise anyone listening to this that this work really started in March of 2020. This is the very beginning of the pandemic. We were hearing about folks getting denied right to those support folks. And so Oregon Health Authority stepped up and they published a visitation guidance in part to help say, hey, yeah, hospitals, we've got your back. You should probably be limiting who's coming and going to mitigate the spread of the virus. But we started seeing again those unintended consequences. So in June of 2020, the Oregon State Legislature convened a special session to look at laws or practices or things they needed to implement to help the state and all Oregonians deal with the public health crisis. And in response, in July 28, 2020, Oregon Health Authority adopted some temporary rules to implement. And so you can see how quickly this happened. There was a bill introduced in June. The next month, there are temporary rules. And then the very next month, in August 2020, those rules took effect. And then following in September, there's a rule advisory committee to provide impact or input to make the rules permanent. And the reason for this is while we were moving quickly made sense, right? We wanted to make sure patients with disabilities weren't being discriminated against or denied their rights. But at the same time, we wanted to also make sure that we were balancing all of the things that were going on in the pandemic. And so by January of this year, the Oregon Health Authority adopted permanent rules, and those rules went into effect. And so what we've been doing together since then, Disability Rights Oregon and the Oregon Health Authority, is just pushing that information out. And that's part of why we're here today. So next slide, please. So who can access a support person is a very common question. So we just decided to get that going right away. When a patient is admitted to the hospital or is in the emergency room, part of what we want to happen is for both the patient and the staff to ask themselves, hey, do I have a disability that impacts my ability to make medical decisions or understand medical advice? And in that initial conversation, it should be, yeah, this person has a support person or this person is a care provider who's here. Instead of that person being turned away, they should be invited in to be part of that support. The other thing to look at is if they need assistance with activities of daily living. And again, this is a good example is when the existing hospital staff just isn't sufficient to provide that support. And then finally, if someone is deaf or hard of hearing and has unique communication barriers and needs assistance to effectively communicate. And this is the thing, with all of these examples, what was great to see is everybody agrees that having a support person helps the patient, and it also helps the medical care team trying to help that patient. And so there's some real great consensus that yes, we need to have those support folks in the room helping patients navigate sometimes some pretty scary medical decisions. Next slide, please. So these are really the big four categories that I like to look at of, okay, what kind of support are we talking about? That support can look like help with communication. And by the way, we've talked a lot about interpreters, but communication could always also be someone who is nonverbal or has limited use of words and help them communicate. The other key area of support is making healthcare decisions. This may be true for someone who has an intellectual or developmental disability. It could also be someone like me who has anxiety, and so they're in the middle of an anxiety attack and they're having a hard time making a decision because they're flooded with feelings. And so having that support person there to help understand who they are and help them make decisions is really important support. The third category is understanding information. And again, this is part of the communication, isn't just going out to the medical providers, it's also helping information come in. And then finally, the engagement and activities of daily living. And again, this could be transferring, it could be eating, it could be anything that someone needs to stay healthy and safe while they're in a hospital setting. Next slide, please. So then the next question is, we talked about support, but who can be a support person? These are the 4 general categories we've seen in this work. The first is family members. Second is guardians or people who are otherwise authorized to be someone's healthcare representative. The third is personal care assistants. This could be a personal service worker or someone else that the individual has hired or has on board to help them throughout their life, whether it's at home or at work. And then any other unpaid or paid attendance selected by the patient. And this is the part that I want to really focus on, that selected by the patient is a really key part of this. There are times where people really want to do the right thing and they see someone with a disability and then they might assume, oh, you need a support person. You know, part of this is the right to choose a support person, and it's ultimately up to the patient to say whether they want someone and who they want. Next slide, please. So here are the other key elements of the law that I think are important. First and foremost, patients can select up to 3 or designate up to 3 people they want to be support persons. And that includes 1 person that can be with them the entire time they're in the emergency department. These are 2 key elements because for folks who have paid support workers or frankly family members, it's nice to have that person be able to take a break and go home and then come back. And so we wanted to make sure that folks could rotate in to provide support. But also we understand that emergency departments are small and have limited space. And so as part of the conversation with healthcare providers, we said, okay, let's make sure there's at least 1 in the emergency department. So that people, because again, those are where some fast medical decisions are being made and you want that support person there. The second element is that hospitals can and have set reasonable conditions for support persons. That can be anything, including from screening for COVID-19, appropriately wearing personal protective equipment, washing their hands. In one situation, I know that there was a support person who kept coming and going multiple times in an hour and not washing hands or wearing PPE. And when the hospital said, hey, can we just please make sure they're wearing the PPE and they're washing their hands? Yes, that's a reasonable expectation. And then finally, hospitals must inform patients of this right. I like to say rights are only as important as you know about them and you know how to enforce them. So this presentation today is about how to enforce them, but what if you don't even know about that right? So something that Oregon Health Authority has been tremendous in is making sure that hospitals know that this is something they need to prominently post in the hospitals. Next slide, please. So I think this is where I'm turning it back over to you, right, Anna?
Yes, and I will just jump into that last slide for a second and say, in terms of informing people of their rights, we required in the rule that hospitals have to post information and they have to put their full policy on their website because we want to make sure people know about this and know how to find it, so that one piece of paper in the hospital entry has to tell you where you're going to find the whole thing, and you're going to find the whole thing on their website. So the support care conference is what should be happening if the hospital denies a patient support, their right to have the support person with them as an admitted patient or in the ED. And that can also mean if they limit on the number of people, saying you've got to be with the person for 3 weeks straight, nobody else can come in. Or if they say, well, you can have a support person, but it can't be that one. They could say that if that person says, I'm not wearing a mask, well, then the hospital can say, no, you need to wear a mask. But they can't just say, that person isn't paid. They can't be a support person, because the support person can be paid or unpaid. So if a hospital denies the right to a support person, they need to inform the patient that the patient has a right to a support care conference. And then the patient or the support person can request that support care conference. The conference should be held as soon as possible, not later than 24 hours after admission. And it can even be happening before a procedure or an operation or before an admission. If you know you're going to be going into the hospital, you can reach out in advance and say, hey, I have a support person. I'm going to need my support person. And if they say, oh, sorry, no, well, let's have a support care conference before I show up so that we can get this all sorted before you even get to the door. Next slide. So who's in that support care conference? The support care conference can be held in person. It can be held by phone, by Zoom, by Teams, any other electronic meeting platform. And it includes a representative from the patient's hospital care team, the patient's legal representative, if there is one, and the patient's designated support person or support persons. And sometimes an advocate from the OHA COVID feedback team is also present if they have, if they've been working with this patient or with the support person. Now, because you're looking at how quickly can you do this, a patient may say, well, I've designated 3 support persons, but I only need 1 person there. Okay. Or a patient may say, there's a person who's not one of my support people, but who'd be really helpful in providing information. Then it's worthwhile to see, well, can we include that person? Again, we want to get it done as quickly as possible because you don't want that patient to be without a support person beside them when that's necessary, but other people can be included. Next slide. So what's the outcome of the support care conference? Following the conference, the hospital has to document the outcome in the treatment plan and provide any reasons for limitation, restriction, additional precautions, or prohibition. Additional precautions could be, well, we're going to be on a floor that has a higher infection control protocol. And so in addition to a mask, you also have to wear a gown and booties. Good, let's get that documented so that everybody has that and they know what to expect. And same with limitations, saying, well, here we are in a treatment area where there are lots of other patients and they have freedom to move around, then this is what you will do to protect their privacy and still provide support. So all of that should be documented in that support care conference document. Next slide. So some of the barriers that we see at this point are lack of awareness or understanding of the rule. And we see that both on the side of patients and support people, and we certainly see that in hospital staff as well. And we definitely have had issues with the hospital frontline staff that's very focused on providing patient care and being able to do those day-to-day patient care tasks and may not have a great understanding of legal changes that are happening at the legislature. There are some gaps in provider processes and procedures, and there are differences between hospital units. So the emergency department may have a different understanding than the inpatient unit has of what the law means and who the best contact person is to find out more. There is definitely confusion about the qualification of people with acute disabilities, and there is sometimes the rationale of COVID-19 risk, despite the guidance we have from the CDC, from Medicare, Medicaid, about what are the protocols to mitigate the risk of transmission. So it's a balancing act to make sure that everything is being done so that we don't have COVID coming into the hospital and spreading within the hospital. And how do we make sure that patients with disabilities are still getting the treatment they need and getting the people on their treatment team, both in the hospital and in their personal life, to work together. Next slide.
Can I
Yeah.
continue here?
Mhm.
Back to the element of this is Emily. On the element of the qualifications of people with acute disabilities, I think a good example of this was a really well-meaning intensive care unit nurse called because they were dealing with a patient that was put into a medically induced coma, and they didn't want anyone in the room to ensure that the patient stayed essentially asleep so that they could fight the virus and survive. And the nurse asked me point blank, do I have to have a support person in there? Because otherwise they need someone there to help communicate, but we don't want them communicating. We want them to stay asleep and fight and use all of their power to fight this disease. And I said, no, I think if the medical determination is that person shouldn't have anybody, including a support person in the room so that they can sleep and stay sedated, that would be an example of a reasonable a reasonable pushback from a hospital to having a support person there. So I just wanted to provide that clarity to help explain it, because when I say qualification in person with a disability, sometimes people think it means something different.
I think that's a great point. And one of the things I think about is, because I always think, how can we prepare in advance before you go to the hospital? How do you know what to say so you get the magic words to end up in the right spot? And I think it really helps for both the support person and the person with the disability, if they are communicating that way, to be able to say, these are the services this person provides for me, and be able to boil that down into an elevator speech. That 2 minutes, I'm going to tell you what I do. I'm going to tell you how I can help this person, so that frontline staff can hear directly from the patient or the support person, this is what this person does. And then you can have that conversation about, well, they're going to be asleep, they don't need that service. Or, wow, that's really helpful. It's helpful to know that I'm not going to be able to just talk to the patient without your help. And that's how we get a better treatment team together. That's how we get patients taken care of. So if you've been denied a support person, you can ask to talk to the patient's rights advocate at the hospital. And I would say your first step is always to ask for that support care conference. You can email the OHA COVID-19 feedback team, and we have the email right there, covid.19@dhsoha.state.or.us. You can call the COVID-19 feedback team phone number, and they have a voicemail line that's available in 11 languages. And you can also contact Disability Rights Oregon, and that number is also there. And next slide. So we also have a lot more information on the website. There's an FAQ about Senate Bill 1606, and that is on the website for my part of the agency. And that's on www.healthoregon.org HFLC. You can look at the full rule or the full statute, Senate Bill 1606, at the Oregon Legislature's website. And you can also file a confidential complaint at our website, www.healthoregon.org/facility complaints. And what I'll say about the complaints are, our complaint investigations are retrospective. So we come in and look at what happened in the past, and we compare it to what happened to other people. So we'll look at a sample of multiple patients and who were similarly situated, and we'll look and see, were there violations of the law regarding any of those people? But we don't have the authority to go in and tell the hospital, right now, this patient here, treat them differently. And we don't have the ability to go in and tell hospitals they're doing something wrong without being in the process of an investigation. So we can't just call them up and say, somebody told me you're doing something wrong, knock it off. We have to go in and do an investigation, and the investigation is always looking at what happened in the past. So when you have a problem right now and you want to get it solved right now, the complaint isn't going to be satisfying, but that support care conference is really going to be your best first step. And then in federal law, we have the Office of Civil Rights, and they have an online portal for complaints.
But I was going to say, Anna, I think if someone's being denied a support person or a care conference right now, I think still making a complaint to your office makes sense, as well as to mine. Unfortunately, I've been in a position of making those calls and saying, what's going on? Can you make sure this person's rights to both a support person or a care conference are upheld? And I'll tell you, 10 times out of 10, that direct line staff just didn't know, and the problem's corrected. And so if it's happening to you or a loved one, know that that's the position my office has been in, is to help advocate and educate some of these providers about the parameters of these rules that they may not know about.
Okay, next slide. So with the COVID Response and Recovery Unit, they created a great one-person or one-page flyer about this, and it's available in multiple languages. Some of the hospitals are actually posting this, but it's meant for patients to have themselves. And so it's available on our website, it's available on the COVID website, and there are links to all the language options. Next slide. I understand we already have some questions.
Awesome. The one thing I'll just say before we jump into questions is OHA's fact sheet is such an important tool. I have lost track of how many people I've talked to who said that, you know, when they initially got pushed back at the emergency room or weren't quite sure, when they had that fact sheet in their hand and said, no, I do have a right to this support person or this care conference. It has been so very important. And so this is my chance to just pause and say thank you, Oregon Health Authority, for your leadership around this and the guidance, so that folks, when they're in an uncertain place, have a certain document that they can pass off and move forward that way.
And I will add to that and say, I think the document is really helpful, and I think it helps both providers and patients. My big caution is, I know a lot of times we hear about patients going in with a stack of documents. I have an evaluation of my needs, and I have this letter about how I interact with doctors, and I have this copy of the law, and I have this other thing. And the patient then gets to the emergency room where the staff says, I don't have time to read any of that. And so my analogy for this is, if my house is on fire, I could walk up to the fireman and say, I have the plans and I have a document that describes my house, and I have this other document that tells you where the things are in my house. But it's probably going to be a lot better if I say to him, the door at the top of the stairs is locked, you're going to have to break through, and I store extra propane in the basement. You should watch out for that. So your documents if you have more documents, they may be helpful in a support care conference, but when you're in the emergency room, what you want to do is be able to say just briefly, these are what my needs are. This is the service I need this person to provide. And they don't necessarily have time to read documentation to support that. You can let them know you have it, but part of your job as a support person and your job as a patient is to help them get the minimal amount of information they need to then provide the care that the patient desperately needs quickly. So I love that one-page flyer, and I think it's great to be familiar with it. Keep in mind, the staff may not have time to read it or to read other things. And so one of the best jobs a support care person can have is to very briefly explain what are the needs and then move along in that process.
This is Christine, back on screen again. Thank you so much, Anna and Emily. I forgot to give my visual earlier, so for those who don't have complete access to your screen, I'm a white woman with long, dark, wavy hair, gold sweater, red lipstick, and a gray background. And so next in our recording, we would like to address some common questions that were submitted by community during the registration process for this webinar. So I'll just dive right in and you guys can answer as you see fit. So the first one was submitted by someone who identified as having a disability. They said, can I have a support person in an outpatient setting?
That's a great question, because what Senate Bill 1606 made clear was a law that's been on the books for 31 years now, and that law is the Americans with Disabilities Act. And what the ADA says is any public entity, including outpatient clinics, doctor's offices, lawyers' offices, any public place has to reasonably accommodate people with disabilities. And so while Senate Bill 1606 was exclusively focused on hospitals, primarily because, again, hospitals were changing their visitation guidelines during the pandemic to inadvertently reject this critical support, the ADA still applies. And so if you're going to an outpatient setting or a medical office and you need a support person there and they're limiting visitors there too, you can certainly say, hey, I'm a person with a disability. I need a support person. Can we engage in the legal terms, I'm using air quotes here, is the interactive process where the person with the disability says, hey, this is my disability, this is my need. This is what I think is reasonable to meet that need. In particular, I need this support person there. And then it's the medical entity's responsibility to then respond to that. What I would absolutely urge you to do in that circumstance is have that conversation prior to showing up for your appointment. That way you can show up and everybody's on the same game plan, the same page about what the patient needs and how to accommodate them. Anna, anything you wanted to add to that?
I would just say that 1606 provides some formal structures for how that works in admitted and emergency department patients, but it is really all building on that same foundation. And so maybe the magic words are a little bit different when you're dealing with 1606, but it's all about how do we get everybody on the same page to figure out how can we best support this patient. And I know Coco has some information to add, so I'm going to throw it to Coco.
Hello, my name is Corian Coco Thomas. My pronouns are he, his, him. I'm a Black man. I am deaf blind. I have a salt and pepper beard. I'm wearing a black cap and a red jacket with a brown shirt underneath. And I am one of the A-Team accessibility coordinators for the crew. One key thing is that it's important for people to address things to the office manager because they are the people who really know these things. So while individuals may know their rights and the ADA and 504 Rehab Act apply to these settings, and now in addition to that, we have Senate Bill 1606, conversations with the office manager can be really effective in discussing what specific accommodations and needs that you have, because the office managers are the ones who are really aware of those policies and things like that, and not all hospital staff are aware. I just wanted to add that.
This is Christine. Thanks for that, Coco, and everyone. That was wonderful. Next question. So how can a support person request a support care conference?
This is Anna. I would say a support person would request a support care conference in the same way that a patient would, by telling one of the hospital team members, hey, we really want to have a support care conference. I'm being denied the right to be with this person who's requested my assistance. This, the patient has a disability and has indicated that he or she would like my assistance. I want a support care conference. There really aren't any magic words, and there aren't necessarily any magic people you want to find, but you may find that the frontline staff providing the treatment or a security person at the door may not know a whole lot about what you're talking about. On the bright side, the hospital has their posting that says 1606 applies here, and it has to have a contact name. It has to have the name or a department to get in contact with to find out more about how you can use those rights at this hospital. So that's going to be a great person to reach out to. You can reach out to the hospital's patient's rights advocate. That's another choice, but it isn't a question of who's asking. It's either the support person or the patient can ask, and both of them can trigger that process. Emily, do you want to add?
You got it, Anna.
Wonderful. Thank you. All right. So the next one I know you touched on earlier, but I want to verbalize it again. The question is, how does this rule apply to patients who are nonverbal, unconscious, intubated, or unable to communicate their need for a support person?
I'll start with the first example, the person who's nonverbal. My friends and folks that I know that are nonverbal, they're very good still at communicating what they want. And so I think that's where we really need to like make sure that they and the folks around them feel really comfortable saying, this is how this person communicates. And oftentimes it's facial language or hands or eyes. And really the support person there is simply to help effectuate that communication up to the care staff. But for folks who are comatose or lack the capacity, whether it's temporal or not, to say what they want, I think this is really where each and every one of us should probably have some sort of advanced directive or decision making about how and when we don't have capacity, we want decisions to be made. This is something we should all do. That way, when we lack that capacity or we're not able to say what we want, everyone around us knows what we want and can try to make that happen. Another example of that I mentioned earlier was the healthcare representative. Anyone in Oregon can say, I want this person to step in for me if I'm not able to make decisions. And so there are a couple of different instruments and tools to make this happen. But I really, I think thinking about how people communicate creatively is really important. One of the things that's up on DRO's website is a medical decision-making toolkit for folks who are nonverbal, and it uses images that someone can, when they're home and not in an emergency, can maybe circle or point to the things that's important to them that their care providers and their family and friends have around them, so that that can be the tool. And so I think just figuring out what people want and having people there to say what that is another fundamental reason why the right to a support person is so critical and why this law passed.
And I will say, I agree. I think it is hugely important to know before you go, to have that game plan before you have to go to the hospital, so that both the patient and any of their support people know these are the expectations, these are my needs, and this is how we're going to express that. And this is how we're going to be able to communicate that to the hospital, so that they understand this is a person with a disability, these are the needs, and how does that fit with what the hospital is doing. I think the things I want to pay attention to when these questions come up, especially when we talk about unconscious or intubated, and it can also be unable to communicate, is that part of a disability, or is that a response to the treatment being provided by the hospital or to the underlying illness that's causing the hospitalization? For example, if you go into a hospital for surgery, you will likely be unconscious at some point. That doesn't mean that you have a disability. You may be a patient with a disability who's going in for surgery and ends up unconscious, and you may be a patient who does not have a disability, or who has a disability and does not select to have a support person. So the question is really, what is it that's happening, and is it related to your disability, and is that a service you need? Because for everybody who's going in to the hospital for surgery, when they are unconscious, the hospital will provide care for them. If they need a support person, the question is the support person to do something other than what the hospital is already going to do for everybody who's unconscious that day? So that's always what we want to be looking at. And there are certain situations when either the illness itself or the treatment will create something that in the long term could look like a disability, but in this brief period isn't necessarily a disability. So that's why we always want to have that conversation and figure out, is this a person with a disability, or is this a person who's unconscious because the hospital made them so, and then the hospital will undo that. And always, if it's a patient with a disability, having that conversation beforehand with the support person, and having the support person and the patient be able to communicate to the hospital, these are the needs that we need to meet.
Great, this is Christine again. This next question kind of follows up on that, and it's, is proof of a disability required to have a support person?
Yes, Emily, and no. To be a qualified person with a disability, you have to identify that way and ask for that support, but there is no proof that you have to provide.
I've got nothing further to add.
Perfect, thank you. This is Christine again. Okay, let's say they are in the hospital with their support person. Is there a time limit for a support person's stay?
There's no time limit imposed by the rule or the law. I think this is a conversation with the patient and their support worker about, how long, and this is probably should be, what already this person provides. Some folks have support workers rotate in and out every 4 to 8 hours, but they get 24-hour care. Some folks only need support workers around certain periods of the day, like getting dressed and getting ready, and then getting undressed and getting to bed. And so it is so individual patient specific that this is the exact room for the patient care conference to be talking about those parameters, about who's coming in, who's rotating. And remember, those designation of those 3 support people, as Anna mentioned, that can change. I can say, here are the 3 people that are going to be on this week, but next week it's going to be these other 3. The limitation on 3 is both about figuring out the time, the segments for the patient, but also making sure there's some sort of number. So you don't have 12 really fantastic support people in the patient room at a given point. We knew we needed to have some sort of limit there, and 3 seemed reasonable. But I think there are no hourly limitations, though that has come up. Anna, do you want to talk about that a little bit?
Sure, and I would say that those same time issues apply for unpaid support persons. If you are a support person who is there to support a patient with a disability as a family member, as a friend, as a neighbor, you still may have limits on your time where you say, well, I can be with you for 6 hours, but I can't be with you for 24 hours. I have other responsibilities, and that's okay. And that's, again, part of that conversation to figure out, well, what's a reasonable amount of time? We have definitely had situations where we've been concerned where a hospital says, well, you can have 1 support person for your whole time. And if you're in the hospital for several weeks, that may not work for a paid or an unpaid support person. On the other end of the spectrum, you may have a support person who says, well, I'll be here for this hour, and then another person will come for the next hour, and another person for the next hour. That may be too much of a burden on the hospital to be screening all of those people coming through and making sure they're all wearing PPE and making sure they all know what the hand washing protocol is. So it's a conversation you need to have to figure out what's going to be reasonable in terms of how long can the support person stay? How long are they paid to be there? How long do they have the freedom in their own life to be there? And how many people can the hospital system tolerate coming in and out? And it may differ by what part of the hospital you're in, what kind of unit you're in, the needs of the patient. There are a whole lot of factors to look at. So there isn't a single time limit, but if the limitations that are being told to you are not workable for you, that's a perfect time to say, let's have a support care conference. Let's talk about this and figure out together what's going to be workable.
This is Christine again. There's only 2 more, I promise. So the next question, you have all been really great at leading up to the next question. Don't know how you're doing that, but it is, how can someone be a good support person?
I will start. Oh, you want to start?
I don't know. Let's Rochambeau. Go ahead, Anna.
I would say a good support person probably already knows how to be a good support person because you're probably already providing that support outside of the hospital. A patient with a disability needs to really look to who are your current supports, who knows you, who can help you meet your needs. And those are the people you want to designate and reach out to and say, that's who I want as my support person. So that's, you're taking the person the person you can already get assistance from, and you're moving them into this setting. So then the question is, well, how can they provide the help and support in this setting? And I think, again, it is always about supporting the patient in their wishes, in their decisions, and helping to facilitate that communication with the hospital and helping to be part of that care team. Just like the hospital has a care team of respiratory therapists and nurses and CNAs and doctors, you're part of that patient's team. And how are you going to work with that hospital team and figure out what are the needs that I can meet, and what are the needs that the hospital is already used to meeting for all the patients.
I agree with everything Anna said. The only other thing I'll add is it begins and ends with the patient. And so it might be the patient says, actually, I don't need you here, right? And that's the patient's choice. So the patient says, I'm so glad you're here. You're my support person, but I kind of want you to go home. That's, you know, following and complying with what the patient wants is the beginning and end. And it could also be the other way. Hey, I know you don't want to make hay, and they're saying you have to go in 4 hours. I do not want you to go. I need you to make hay. I need you to call these numbers or ask for a care conference. I think at the end of the day, most support persons understand this, but it can be hard when you're dealing with a system or a structure where that there's just a different power dynamic. But your dynamic to focus on is your dynamic with the patient, and that should just be the main focus.
Thank you. This is Christine again. So the last question came up a lot. I think we have a general answer, but I will read out that there were many questions about payment and billing for paid support staff. And the question was, what should a paid caregiver do if they have a question about payment for the time that they spent with the client who is hospitalized?
So I will jump in and say there are a large variety of programs that pay for paid support staff for a whole bunch of different programs within the state. There are some programs that are part of the federal government. There are, I'm sure, some private agencies as well. So the first person to ask about these questions is always whoever you've arranged with to provide this service. If there's a caseworker, if there's an agency person, that's going to be the person who can help you figure out the answer because it is going to be very much program specific.
This is Christine. Perfect. Well, do our presenters have any closing thoughts?
I'll just repeat that I think the past 23 months has been really hard for the world, and it certainly has been hard on our state and the folks with disabilities and everyone trying to serve them. What I really love about this law and this conversation is we all just rolled up our sleeves and said, what are we going to do about this? How are we going to make sure, even with all of this uncertainty and all of this fear and all of this loss, that we can preserve and protect the integrity of all patients, including patients with disabilities that need these support folks so that they get the care that they need. And so I just think this is it's really wonderful when we can have success stories like this and partnerships like this. And I want everyone listening to this that maybe went through this scary process or maybe going through the process and going to the hospital is just tough for everyone right now. These are guardrails up for you. And we are here to help implement and support and make sure that we can continue on the success that we've achieved with this law and with this outreach effort.
And I would thank everybody who has reached out and who has shared information and who has told us how this has impacted them, because that gives us more information so that we can help somebody else figure out, how do I do this better? And we can help a hospital figure out, how do I do this better? How do I help families and help patients with disabilities in this time that is scary and confusing for everybody? And I would say, even in a non-pandemic time, going into the hospital can be scary and confusing, and it would help to have somebody who could be there to help translate and be another pair of ears for just about everybody. And this law is really focused on how can we make sure patients with disabilities get that support that they need in the hospital setting. And then look at that when we have the question about outpatient settings, remembering, there's already a law here. We just need to know about it and know how to use it so that we can get the patient and their support team to coordinate with the medical team. And I think when we do that, we have better patient outcomes and we're protecting the rights of all of the people who are seeking care.
This is Christine. Thanks so much. Coco, did you have one more thing to add?
Yes, Coco here. This information is really beneficial for all individuals. And recognizing that individuals have diverse needs when it comes to accessibility might seem overwhelming, but it really just requires that you look at each person and consider, what are their access needs, what providers might need to be involved, and make sure that that information is shared with the hospital or the clinic or wherever it is that you're going. So it's important that people are trained in what their rights are and have that information about what's available. It's so key to ensure accessibility is provided successfully.
This is Christine. We are all smiling and nodding along with you on the screen, Coco. Well, I think we have neared the end here. I want to thank Erin, Anna, Emily, Coco, the accessibility team and the COVID feedback team for helping bring this together. This concludes our webinar on Senate Bill 1606. Thank you everyone joining us virtually. We hope this has answered your questions and that you feel equipped should you need these supports. Be well, everyone.